Welcome to Talk the Walk podcast. I'm Jaynie Morris, and it's great to have your company either for the very first time or if you have been listening to our Talk the Walk podcast, this is our series 2. We welcome you back again. Now, each episode we speak with guests who are making a difference, changing the way things are happening out in the world, and also have something very important to say. My guest today, Professor John Mendoza, we've invited him to come on Talk the Walk. His background is he is director at Connecticut Consulting, former chair of National Advisory Council on Mental Health, CEO of Mental Health Council of Australia, adjunct professor of health science at University of Sunshine Coast and the University of Sydney. Professor John Mendoza was the former head of Adelaide's mental health services. And that is the reason that we've invited him to come on to our podcast today, because Professor Mendoza resigned after only a year of his 3-year contract with the South Australian Health Authority. And it was out of protest of the South Australian government's inaction to the crumbling health system and mental health system that is happening here in South Australia and Australia. So, Professor Mendoza, welcome to Talk the Walk.
Thank you, Jaynie. Lovely to be here.
It's great to have you here. I'd love to say that this was a conversation of positivity and optimism, and I'd like to hope that at the end of this conversation we do have that. But Professor Mendoza, as I alluded to in the introduction, and it certainly didn't do justice of what has occurred, this is a very dangerous time in the community for the health system. And I wonder if you wouldn't mind filling in the gaps from my introduction, please, of what's going on and what you've been going through.
Yeah, look, thank you. And thank you for inviting me to participate in these podcasts. Just so listeners outside of South Australia and even within South Australia understand the structures of the health system here, we can talk about the portfolio of health within the government. And then there is basically a central department that's called the Department of Health and Wellbeing. Often people refer to as SA Health, but the whole entity is SA Health. Under that Department of Health and Wellbeing, there are then 13 further agencies, if you like. And the biggest of those is known as the Central Adelaide Local Health Network, or LHN, CARLN for short. We've got the Southern, which is probably the second local health network, and then we've got NARLN, which is the Northern Area Local Health Network. And those three networks cover the greater Adelaide region, a region of about 1.3 million people. The other entities largely cover the rest of the state. So the regional and rural areas have a number of local health networks which cover their districts. And then there is another couple of statewide services, most important one being Wellbeing SA, which is designed to really focus on health promotion and prevention. And the government, the current government, the Marshall government, set up this rather complex arrangement when they came to power. And I've got to say right from the outset, it struck me as odd for a state of less than 2 million people to have all of these health entities. New South Wales, with a population of well over 7 million, approaching 8 million, has nothing like that number of entities for the provision of public health services across the state. So they've gone on a very complex design sort of model here, a heavily bureaucratic model, and that tends to get in the way of good, rapid clinical decision making and ensuring the resources are available where they're needed. And that's certainly been my experience here. It's a very cumbersome, I've referred to it in the public commentary as ossified. It's an ossified bureaucracy that is unresponsive to the needs of the community when it needs to be able to be more agile, like in the context of a pandemic. And pandemics by nature not only have an impact on physical health through the viral transmission, they also have a profound impact on the mental health and well-being of communities. And we've seen this around the world. And so I saw a situation in South Australia. I took on the job prior to the pandemic. I arrived after the pandemic had started. But my purpose in coming to South Australia and being asked to come and head up this core service responsible for 40% of the mental health services in the state, all the prison health services, was the urgent need for reform. Now, the pandemic has basically doubled down on that urgency, because there were these long-standing problems about long periods of wait in EDs for people with mental health problems, stuck in emergency department for days on end, and then very poor outcomes associated with that for all concerned. But the pandemic has made that far worse. And my frustration in the end resulting in my resignation, and then being dismissed for speaking publicly about this problem, was that there was really zero response from the government and from the department in terms of addressing this need.
Why do you think that was, Professor? Why do you think that for such a vital area of the community need in the health system, that there was nothing there for you? Why do you think?
Well, look, to again put some context in this, mental health throughout the Australian healthcare system, and indeed more globally, is the Cinderella of developed healthcare systems. So if we look at Australia, UK, Canada, even our cousins across the ditch in New Zealand, the relative quantum of funding that has gone into mental health really in this period, ever since the closure of the old asylums, the old standalone psychiatric hospitals, which began closing in England, in the UK, it began there in the 1950s, and for very good reason. It's not as if this was a cost-cutting measure as a starting point. It was a human rights issue right from the get-go, and it was also apparent that we could provide better care for people in the community because of the new generation of psychotropic drugs that were becoming available, antipsychotics and so forth, and also newer treatments. So it had evidence to support that trend. It wasn't merely government saying, oh, here's an opportunity to cut costs, let's close all of these beds. Australia had at sort of about the mid-60s, around 30,000 of these beds in institutional care. We're now down to about 6,000 beds in our general hospitals and in our remaining standalone psychiatric institutions. And people might say, well, that's terrible. You know, our population's gone up dramatically, and that's true. Unfortunately, what hasn't happened, Jaynie, is that the quantum of funding required to respond to the mental health community's needs has not come forward by any stretch of the imagination. The Victorian Royal Commission into Mental Health finished its report earlier this year, and as a consequence, the Victorians are going to basically double. The Victorian government under Daniel Andrews has committed to basically doubling the amount of investment in mental health services over the forward estimates of about 3 to 4 years. That's what's required in every jurisdiction in Australia. We collectively, all of our governments, all of the governments of the Federation and the Commonwealth, collectively spend about 10.5 billion per year. But the cost of mental illness to the community, the Productivity Commission put a figure on this for the first time ever this year. It's $220 billion, or 10%, a bit more than 10% of GDP. So it's just not in sync with the needs, and particularly what we know about mental illness is that it's not just 1 or 2 occasions of service that people need. They may need ongoing service for the rest of their entire lives, with an early onset invariably under the age of 25. 3 out of 4 serious mental illnesses will develop before the age of 25. And so that means that on and off, if not continually, through that person's life, they're going to need access to good care. Whereas if I experience a cardiac event, I will probably need good care for about 12 to 18 months, and I will get that. Similarly, if I have a treatable cancer, and most cancers are, I will need a period of treatment and then monitoring through remission in order to then, continue my life. Mental health is different. And so it's why mental health is responsible for 1/4 of all disability burden, And when you combine it with the neurodegenerative diseases of older age, you know, the things like Parkinson's, Alzheimer's being one of the dementia illnesses, and so on. Those two categories of illness now occupy about 50% of all disability burden. And yet we do not invest in either the prevention or the ameliorating of the symptoms so that people can participate in life, pardon me, and live with their illness in a sense. And so we have this enormous number of people who are simply put on the park bench, so to speak, or to use a sporting analogy, they're off the player list. They're no longer eligible for playing, and they're put over there, and, you know, we hope that they'll get better somehow by an act of God or something. But we don't provide that sort of continuity of high quality care. And the problem we see manifesting in this state and around the country is that because of that lack of continuity of care, people who have severe mental illnesses, disabling illnesses, they're discharged from hospital after a short inpatient stay, and then they cycle back through. And we have people who will spend anything around 200 days a year in inpatient care, but they will do that through 20 or 30 visits. So they're in and out, in and out. And they're a relatively small group of people, but we're not providing what we know works. And as a consequence, we get this huge impact on those relatively scarce resources of inpatient care.
Professor, we've received a lot of communication at Sheroes Unlimited in regards to this topic, because it is a growing community issue, hence one of the reasons why we wanted to have you on the program today. In what you've just said there, one of the things that has come to light through these communications are questions like this, and we'll put them to you. Sure. So, for instance, as you've just mentioned, you know, there are some cases that cycle through sometimes up to 200 times throughout the course of a year and what have you. Some people have written to us and said that they have children, adult children, that have been diagnosed with Asperger's, for instance, yep. And in some cases, when they've had what they call an episode in their home, living independently, police have been called, and the police automatically take these individuals to the emergency departments of our hospitals, and then are to be seen by professionals there. In most of the cases of the people that have contacted us about this, they're taken to the emergency departments, and within less than 24 hours they're released, being told after seeing somebody that because especially, as you know, with Asperger's, it can present completely fine in 1 minute and then not in the next. Oh no, there's nothing wrong with you, go home. And yet in that 24 hours, those individuals have taken beds in hospitals, in emergency situations, and not being given specific mental health accommodation or support or so on and so forth. So I guess my question to you on that one is that why then in the health system, and we'll talk about South Australia, when we do have this massive increase in requirements and needs for mental health care in our community, why is the government not creating those facilities? We had Glenside, for instance, which was then taken away and turned into a housing development and things like that. We have facilities like the former Wakefield Hospital that is now up for lease. Why don't, when we have this crisis and we have incredibly talented and experienced individuals like yourself who have come on into the state to assess what's going on, why aren't they going, let's turn Wakefield Hospital into a specific mental health facility, for instance?
Sure, and you know, it would be potentially a good site for accommodating people with lower intensity issues, like anything on the autism spectrum disorder. There's a range of illnesses there. Asperger's is one, or conditions. And at times it's a behavioural management problem more so than anything, that the person becomes really difficult to manage in the home environment, and the family needs some respite. Now, I've got friends who have got children and now young adults with an ASD diagnosis. And as they go through that adolescent and transitional years into adulthood, they can be very challenging in that home environment, and the family needs respite. We don't have those sort of services. We need them. And it's not as if this is a sort of a very niche need in the community. This is a common problem. When I began my career as a teacher, one of the first things way back in 1976, I spent time at the autism specialty school in Brisbane. It wasn't really a school, it was more of a facility at St Lucia, close to the university campus. And so I experienced firsthand there the needs of children with autism. And they had high care. They had ratios of staff of 1 to 2 sort of thing working in that facility. Well, we don't have those sort of things on the scale that we need. Back then, autism was quite rare. It was about 1 in 3,000 children. It's now much, much higher. I don't have the figures in my head, but I know that it's probably a tenfold number of children now on this ASD spectrum. We haven't built the services to support those kids and those families. And often they then also become depressed. So they develop a mood disorder, in a sense, as a consequence of poor treatment and care of their autism or their Asperger's. And unfortunately, too many of these folk do not then find opportunities. We do not have the employment policy to enable them to participate in employment. We have one of the lowest employment rates of people with mental illness in the OECD. If I have schizophrenia and I live in the Netherlands, I'm 3.5 times more likely to have some form of employment than if I'm with the same condition, same severity here in Australia. And that to me is just ridiculous. We are not providing the incentives and the safety nets for employers to say, yeah, I'll take on that person with schizophrenia who's got a diagnosed schizophrenia, and we'll work with them. I've been privileged enough to come across examples, Jenny, in my working career of where companies, even one of our major electricity companies that runs the powers and wires, who deliberately made the choice to continue to employ a young man who was a liney, as they call them, the people that fix the lines that run around our streets in the urban areas. Even despite his diagnosis at 21 of schizophrenia, they kept him in his team. They skilled up the work team, they skilled up the supervisor, they enabled him to take time off, extended periods of time off when he had a recurrence of the episode, when his medication needed modification. And this is in a highly dangerous industry. So it demonstrates they're serious about supporting people with disability in their workforce, but that is a rarity. And that is what I mean. We've got to have both the leadership within organisations, but we've got to have the government policies that enable people to do that. So, you know, our problems are at many, many levels. We are not providing the healthcare, the clinical care that's needed when it's needed, where it's appropriate to deliver it. We allow people to get very unwell in the community. We allow them to drop out of education and employment and become impoverished, which doubles down on their condition. We allow their family, we let their family carry the burden of responsibility, and invariably that leads to breakdowns in the relationship, to the point where the family can no longer have that person, that member of the family living with them. And yet then, you know, the only thing we're providing is this sort of emergency response. Call the police apprehend the person, they then handcuff them, arrest them in a sense, transport them into the hospital, either in the ambulance or in the police car. They then spend several days in the ED where we again double down on their trauma. We worsen their condition. We put them in an inpatient bed for a very short period of time. 10 days is, you're lucky if you're getting that at the moment in Adelaide. And then we discharge them back to the community to nothing. And we wonder why, we have these problems. Well, we're just doing a very bad job at what we should. This is like if we had cancer and we were still treating a cancer as we did in the 1950s, with major intrusive surgery and invariably loss of life within 4 or 5 years. The transformation in cancer care in this country, as it is in the United States, is unimaginable compared to where we were even in the 70s and 80s. And that's what we have failed to do in mental health. We have failed to take that same journey, and that same journey means continuing investment in research, in the workforce, in the types and array of services that we need to enable people to get back to living well in the community.
When you do a community survey of what is the number one priority, or what people think is the number one priority in their communities, it always comes up health. Health is always first. It's health, then jobs, and then the rest of the list, Professor. The stories that we hear in the media constantly now about the ambulance ramping, which is now completely out of control, and about it's code white, is it?
Correct. Code white's the highest level. Yeah.
Code white happening not just on a weekly basis now, but all the time in all of our major hospitals and even our regional hospitals now, because they can't they can't move, they can't get out and get supported. We hear this all the time. It's concerning the community dramatically. It's also, would you agree that the more that we hear this, the more that people in the community, when they do get unwell, or if something they think is serious, that they are hesitant on going into a hospital or calling an ambulance because of this? Are we not creating a danger upon a danger?
Well, we are, and that's exactly what's happening for many people. They see these, headlines and stories of the crisis in accessing acute urgent care, and they're hearing about it. In fact, in the taxi, I had to get a taxi back from dropping my car off for a service this morning, and the driver was telling me about a patient that he had in the car just the other day who was down from Alice Springs. Patient had been flown down from Alice Springs at the government's expense. Commonwealth government, I think, had paid, accommodated, booked for surgery, and then they got bumped for surgery. And there were 4 people that the patient referred to were all in the same boat. So this was surgery that couldn't be done in Alice Springs. It had to be done here in Adelaide. So you start to add up the dollars here. There's a lot of money. They've all now been sent back to Alice Springs, and they're looking at another booking later in the year where they'll do the same thing. And the fellow was saying this is a really common experience for people that he knows. This is an older Australian living in Alice. He just said this is the story all the time. The same thing happens with Broken Hill. The same thing happens with our regional communities here in South Australia. So a Port Lincoln resident who might need a particular, or not even a particular, but just a fairly general sort of surgery has to come to Adelaide. That surgery is booked, but when we have a day like yesterday, or not even as extreme as yesterday at the Royal Adelaide, but any day where we start to go into code red. Now, people might say, why isn't red the hottest or the highest? Well, it's white hot. White hot is hotter than red. So red and yellow and these other codes for the state of the hospital in terms of the numbers of beds available and the capacity to undertake surgery and other procedural work. Even when we get into the yellow and red, you'll see people who have been booked for surgery then having that surgery bumped and then being rescheduled. So we're constantly pushing back people. So if I have surgery booked for, let's say, my knee pain, I've got, I'm on track to have a knee replacement at some stage in the next few years. Well, I'll be able to do that because I can afford to do it through private. But if I was on the public list, it might be clinically appropriate for that to happen now, to have a partial knee replacement, and it wouldn't get worse. My health wouldn't decline. I wouldn't develop other problems because of the lack of exercise and mobility. But it'll be kicked down the road, so to speak, 2 or 3, 4 years, by which time the knee is far worse, the expense of recovery and rehabilitation is much worse. And then there are other problems like the cardiovascular, the circulatory problems, the dementia risks that are raised, all of those things. So this is what's happening across the board. And what we're failing to do is the federal government has largely responsibility for what's called primary care. So this is the services we access fundamentally through our GPs. That whole area is becoming more and more inaccessible to many Australians. I'm not telling anyone in the rural and remote areas of the state anything they don't know. They cannot access GPs when and where they need them. GPs are leaving the bush because the workloads are intolerable. And we have, again, no game plan as to, well, how do we get GPs into the bush, help them stay there, give them something that's a reasonable expectation in work and life balance. And so we see this, continual decline in the accessibility of even the most basic healthcare services in our rural and regional, not let alone our remote areas. So that's compounding our problems. And the fact that the federal government is now talking about winding back a whole lot of Medicare supported procedures, something like 900 of them on the 1st of July will become far more expensive. This again is going to add to the problems that we're seeing manifesting at the public health, at the hospitals, and the associated services that we run at the state level. So we've got these 2 funding arms, one through the feds, one through the state, and the 2 of them are not working together. In my life, I've never seen them at quite a disconnected level as we're seeing at the moment. So there is a joint responsibility here. The federal government has got to demonstrate some leadership, work with the states to ensure that we act as early as we can to prevent illness and to intervene in the first stages of an illness, any illness, so that that person doesn't need the highest level of intervention. And we help people learn self-care and self-management of those conditions, live with their illness, so to speak, as best as they can. And then when there is the need for a higher level intervention, specialist surgery and so on, that those services are available. But we're moving to a situation where particularly people on low incomes, those in the bush, even in our major regional towns, they can't access these services. And so when they do, it's invariably a crisis or an emergency.
I think a classic example that was quoted yesterday in ABC National was a discussion about a consortium of doctors in Broken Hill actually funded and paid for 2 MRI units up there. And they have applied.
No, that's a big investment.
Well, yeah, and they have been trying. They've been applying for the medical provider Medicare.
Yes, yep, to get the provider number,
to get that, and they are struggling because they keep getting told by the federal department, well, when we next open up the invitations for that, then
Correct.
you can, but the next invitation won't be happening for another 12 months. In the meantime, people in the rural community who need those have to drive 700 kilometres to Adelaide to get an MRI done. So I think there's a classic example to back up what you're saying.
Well, and if they want an MRI of their brain in terms of functional MRI, which is one of the 21st century technologies that should be available, they have to go to Sydney. There is no such facility here in South Australia, which I've said, you know, again, in my public criticism of the government said, and one of the reasons I came to South Australia was I believed that the Marshall government and Stephen Wade as the minister was serious about mental health. They kept the oft quoted mantra was mental health is a priority for the government. Okay, well, if it's a priority, and I have the support of the CEO of Central Adelaide, I have the support of the board, I think there's a chance here to do something quite profound. So hence I, you know, uprooted and moved down here more than 12 months ago. That was a furphy. So, you know, if it was a priority, we would have a commitment for the government to have functional MRI here in Adelaide for people with mental health problems. They are a critical tool in diagnostic terms. They are a critical tool in terms of recovery. You know, we can see a child with Asperger's or an ASD perspective illness, we can actually see what's going on in their brain without subjecting them to the invasive effects of a CAT scan or any other sort of, you know, invasive technology. So this is, as I say, just one of a handful of really revolutionary technologies in mental health. You have to go to Melbourne, Sydney, Brisbane, Sunshine Coast, Gold Coast, but not here.
Exactly. Professor Mendoza, the Women's and Children's Hospital, as we in the community have seen with the new RA, I'll call it the new, it's been there for a while now, but for
2.5 full years.
You know, we've seen the increase of the issues for state health as a direct result of potentially things not being done correctly at that hospital, not enough beds and services and so on and so forth. The proposal for the Women's and Children's Hospital, the plans for that, many staff and doctors consortiums associated with the Women's and Children's Hospital have publicly voiced their concerns about the same thing happening with the Women's and Children's Hospital. What do you feel about that?
Look, I've got to declare I'm not at that table of those discussions, or in my past role, I wasn't at that table. However, what I'm hearing them say is exactly what I heard and have heard multiple times from those who still are practicing at the Royal Adelaide, who were there during that design and construction phase, and that their concerns about the design of the ED, it is one of the most shambolic designs I've ever seen. And yet it's a 2017 build. It's bizarre. Their concerns about that facility were not heeded. They were given scant attention. Hence, we have both a mental health unit within the RA, which is not fit for purpose in 2020. It doesn't even have facilities for someone with a physical disability. You know, we do not have rooms that have the appropriate fittings and fixtures for someone who's in a wheelchair. I mean, for God's sake, you know, this is 2020. This was built in 2017. Retrofitting those things at the RA costs an absolute bomb. You know, ligature-proof doors, basic in a mental health unit. I was having to pay $250,000 to get 6 of those doors changed. There are still suicide risk points in that hospital. These were all concerns that clinicians raised over and over again. The same thing is happening at the QEH. The QEH, the Queen Elizabeth Hospital down at Woodville, is about to be redeveloped. It's already started. The design work and the detailed discussions with clinicians has been happening for some time. Again, they have been ignored in relation to mental health. So what I'm hearing over at the Women's and Children's sounds all too familiar, and it'll leave the state again with a poor outcome for the quantum of money it's spending. You know, the RA is the most expensive hospital in the Southern Hemisphere. A bigger hospital with the same functionality was built on the Sunshine Coast for $1 billion less. That's a lot of money to waste on the infrastructure.
And I think also an even better example right around the corner. The Wakefield, the new Wakefield Hospital was built on budget, before time,
Correct.
and is an incredible facility. Before I
And
let you go,
the same goes for Calvary. I mean, Calvary came in under budget. It's a superb facility, and for all sorts of reasons, people thought they could have the Rolls Royce. Well, South Australia doesn't have a Rolls Royce economy to pay for it, and this is the legacy that's been left.
Professor Mendoza, we could talk to you all day, and we do thank you very much, because we know that your time is so valuable and you've got so much going on. Even though you are still in South Australia, but you're actually not in the role that you came here to, but we are grateful to you for being here. One quick last question before we let you go. You did create a 10-point plan for reform. Why do you think the South Australian government ignored you, and why do you think that the South Australian government and SA Health are not taking on board anything that the South Australian community needs for their health system that you have brought to the table?
Well, the 10-point plan, Jaynie, was really to try and stabilise the current situation, because we're in a quite parlous situation at the moment. So one thing I didn't really touch on is that the COVID pandemic has really impacted on those people who were already vulnerable before the pandemic. So those people who don't have a lot of resources and were in precarious employment and so forth. We saw a lot of those people lose their jobs. They didn't get the income support because of the nature of the employment that they had. They're either in the gig economy or casual jobs. They, as a group, have borne the brunt in terms of the mental health impact, and people who are running small businesses who have lost those businesses, they have been really the new wave of presentations seeking urgent support. And can I just make this poignant, this is a really pointed bit of data. 10 years ago, 1 in 10 people that presented to the Royal Adelaide or the other hospitals in the metro area presented for mental health reasons. They had a suicide, thinking and behaviour issue. When I left the job in early April, we were at 1 in every 2 people. So the numbers of people presenting with self-harm, with overdose, with suicidal thinking has dramatically changed. And that is largely driven by economic, sort of precarious living situations, precarious housing, precarious employment, broken relationships. There's not it's not like there's a virus spreading mental illness in the community. What we have is an economic agenda, if you like, for over a decade, which is pushing more and more people into despair and hence trying to get those services. Why did they not follow the 10-point plan to try and stabilise the system, stop the loss of staff, respond to this epidemic? Only they can answer that. But I do hear on the grapevine that some of the things that were in my plan have been quietly taken on board. For instance, we needed urgently what are called psychiatric intensive care beds to relieve some of the pressure across the system. It's not a long-term solution, but it's a very short-term 2 to 3 year investment that was needed. And those 8 to 10 extra beds, I believe, will be in the budget next week or week after, whenever it is. So stand by for more on that. So they won't give me credit. They're too. There's a word for it. I'll let others use it. They won't pay any compliment, but I understand a few of these things are going to happen. So that would be a good thing.
Fantastic. Professor Mendoza, thank you again for your time. What's next for you?
Well, back to Queensland and continuing to teach at University of Sydney. I have a number of projects underway there as well with colleagues and at the ANU. So we'll continue to do what we can to try and get better outcomes for people and communities, who find that the mental health services that they access at the moment aren't good enough.
Well, we wish you all the very best, and certainly from a personal level, as well as all of our listeners, we're very grateful for your time today, and thank you for the work that you did do in that 12 months when you were in South Australia. All the best for the future for you, and let's hope that the health system of South Australia actually starts to listen and make the changes that is so desperately needed for our growing community. Professor Mendoza, thank you for your time. Really appreciate you.
Thanks,
And so jealous you're going back to Queensland.
It's the right time of the year to go back, that's for sure.
It is
All right.
indeed. It is indeed. Thank you so much for that. And thank you for joining us on this episode of Talk the Walk podcast. If you've enjoyed this episode as much as I've enjoyed bringing it to you, make sure that you subscribe and never miss any of our episodes when we talk to special guests who are doing some change, making a difference, and bringing information to us as a community that we need to know. And so from me, Jaynie Morris, to wherever you are in this beautiful, amazing world of ours, I hope that you have an absolutely fabulous day, and we'll see you next time on Talk the Walk.